But a man called Arvid Carlson, looking at these and listening to patients, heard some of the patients saying, well, this drug over here chills me out in a way that this one over there doesn't. And he was able to spot the fact, well, actually, the one that people seem to be saying this chills them out, this also acts on the serotonin system in a way that the one on the opposite side actually doesn't do. So why don't we try and make a drug that inhibits serotonin reuptake, but not norepinephrine reuptake,
Hmm.
and see what it looks like? Okay. And out of that, we get the SSRI group of drugs. Now, I'm getting close to the key points here, which is Carlson thought there's nothing wrong with uh, um, the serotonin system in people who are anxious or depressed or whatever. He thought you have a group of drugs like LSD that act on a normal kind of serotonin system and are going to cause some people to say, yes, that actually suits me and could be helpful. And other people will say, no, that really doesn't suit me and feels awful. So this was not a view of pills as curing an illness. It was a view of pills as things that could do useful things for some people, but not others. And if you ask Carlson, could SSRI drugs cause people to become suicidal? His answer was yes. And a few years later, he was faced with a group of people
What time period are
who
we in
had,
right now?
well, he created the first SSRI in the late 1970s.
Hmm.
Okay. And one of the key points there is that people looking at this now say, well, it was a very rational thing to do. It was very, in a sense, theory based. But no, it wasn't. It was based on looking at and listening to people and believing what people told him. Other people looking at the drugs we had beforehand thought they must all be doing much the same thing. Whereas he was listening to people and operating on what he heard from them. So he creates the first SSRIs, and if you asked him, look, could these drugs make people suicidal? The answer was yes, they could. And he was faced some years later, about the 1990s, late 1990s, with a group of people who had OCD. And the SSRI group of drugs are great to treat OCD. But there was a group of these patients saying to him, look, your drugs don't suit us. They aren't helping the OCD. They make us feel suicidal. We find it's a lot better when we take nicotine. Now, I'm not an advocate for nicotine because my father died from lung cancer because he actually smoked too much. Okay, so I'm not saying to people listening in that you must race out and get nicotine. Okay. Uh, but Carlson was looking at people and listening to them and said, okay, well, let's run a trial of nicotine in OCD in people who do poorly on SSRIs. And the outcome of the trial was, well, actually, yes, there's a very big group of people who have OCD where the first line treatment is SSRIs still, but actually nicotine does a lot can be much more helpful to a load of people who've got OCD than an SSRI
Mhm.
can be.
When you say helpful, what exactly is it helping? Is it helping control their compulsions so they don't repetitiously do things over and over again?
Well, it's more a case, I think, of the reason so many people ended up taking nicotine was not because it's very addictive and you can't get off it. It's easier to get off nicotine than get off an SSRI.
Hmm.
Uh, it was, people aren't totally crazy. When it became clear that nicotine can kill you with kind of heart attacks, lung cancer, and things like that, people got a load more cautious about it. But they also were taking nicotine because it makes you less anxious.
Hmm.
It can calm
Hmm.
a lot of people down.
And
Not
and
all
at this
people.
sorry, at this time, when you say they were taking nicotine, was that in the form of smoked cigarettes?
Yes. Yeah,
Yes.
absolutely. Yeah. But the point I'm trying to make here, and this is where people get awfully worked up, um, if I say to a liberal audience, people who vote for left-wing parties, people who
Hmm.
think we're making progress, we're moving into a world that's enlightened. If I say to them, look, the art of medicine is about bringing good out of the use of a poison, people hiss at me. They hold up the crucifix and garlic, saying, we aren't actually prepared to listen to this guy. If I say that about nicotine, they say, oh yeah, sure, yeah, it's a poison.
Hmm.
You'd be absolutely crazy to take it. But if you're a good doctor working with a person who has a problem, you can bring as much good out of the use of nicotine or alcohol or maybe cannabis or whatever as you can bring from an SSRI.
Hmm. And you're not
And it's
saying
based on
you're not saying like
it's
one's good and one's bad, one's holy and one's evil. You're saying they both have upsides and downsides, and they can be used as tools according to the patient's needs.
well the yeah, yes, a little bit of what I'm saying is that we're all different.
Yeah.
Okay. There were the people who thought Freud was great and the kinds of things he said worked for them, and lots of other people were, more inclined to figure, well, actually, the stuff we're hearing from Jung is great, better than what we're hearing from Freud, and that line of thinking suits us. Loads of other people then think that CBT is useful for them. None of the, I mean, I can see the appeal behind all of these three uh, kind of therapies. None of them work for me.
Hmm. Hmm.
The point I'm making is that we're all different. And the key to me helping you or you helping me is to be able to listen and look and observe.